Moving on to our next session, something different. To chair the session, let me welcome Dr. Chako Varghese, Senior Consultant Nephrologist, SUT Hospital, Pattam, and Dr. Ravindran AV, Specialist in Internal Medicine, Badr Al Sama Hospital, Oman. Welcome, yes.
Very good evening to all of you. Let me at the onset congratulate Dr. Sunil for organizing this wonderful update 2020 on diabetes mellitus. Now let us move on to diabetes and the kidneys. The topic for the next session is diabetic kidney disease, diagnosis and management. As we all know, more than 50% of patients on dialysis all over the world are due to type 2 diabetes mellitus, and it is becoming a big economic burden for countries like USA, Europe and India. And to talk about this very important topic, we have with us today Dr. Rejeesh V, who is a consultant nephrologist, who is American board in internal medicine and nephrology, a specialist in clinical hypertension, clinical adjunct professor in Texas University Health Science Center, and medical director at Davita Dialysis Center. Over to Dr. Rejeesh, please.
Can you all hear me well?
Yes.
Okay, thank you. Thank you for the kind introduction, Dr. Varghese, and the introduction and the kind words. Let me go ahead and share my content. Thank you. Let me Dr. Shabir Rasheed and his team for this great effort to organize this wonderful event. I've been watching also all the great talks, especially I feel grateful to be part of this, especially in my hometown. And also I would like to thank his team to give me the opportunity to talk about this topic today, which will be approach to diabetic kidney disease with special focus on diagnosis and management. The topics I'm planning to discuss today are epidemiology of diabetic kidney disease, a few aspects of the historical events that happened, pathophysiology of diabetic kidney disease, diagnostic methods, conventional therapy, as well as novel agents. Now, I got to admit that I won't be doing justice to the topic in the 15 minutes that I'm planning to talk, but so I'll be highlighting the renal aspects of the main sections of the topic. So as we all know, diabetes has reached epidemic proportions around the world. The 2019 IDF data, 463 million people, approximately 9% of the world population is having diabetes, and 77 million in India. So from the word go, the diabetes mellitus had always had some connection with the kidneys. The word diabetes is a Greek word which means pass through, and mellitus is a Latin word which means honey sweetened. So for many centuries, diabetes was regarded as a disease of the kidneys. Even in ancient India, around 400 BC, the great physician Sushruta, he mentioned about madhumeha or honeyed urine disease. Later on, a lot of works were done by several great physicians and scientists, including Dr. Richard Bright, which many consider as the father of nephrology, who described proteinuria, which later on was called as Bright's disease as well. And we all also know about the Kimmelsteen-Wilson also, who described the peculiar diabetic lesions in the glomerulus of the kidney, which we'll be checking out in the histology sections. So now we know diabetic kidney disease affects 20 to 40% of all diabetic patients, including type 1 and type 2. It remains, as the chair mentioned also, the primary single cause of end-stage kidney disease or causing dialysis therapy in the patient. the incidence of diabetic kidney disease cause of the end-stage kidney disease keep on rising every year. So diabetic kidney disease is considered a progressive renal disease. It's a complication of prolonged hyperglycemia. It's very uncommon within a decade of the duration. Like I said, the highest incidence are seen 10 to 20 years after the onset of disease. So you still have a lot of time to work on to prevent this complication. So this is a conceptual model which was proposed to show the events which is happening. As you can see, from left to right, you move years after the onset of diagnosis, and the hyperglycemia. If you let it persist for those many years, you can see these changes, especially happening in the kidney. So it starts as cellular injury, and if it persists, continues to cause mesangial expansion and inflammation of the kidney. So clinically, what you see is you start seeing proteinuria, then microalbuminuria, macroalbuminuria, and also to overt nephropathy. Initially, you see GFR rise and then normal, and you can see a drastic a drop in GFR as well, and you start seeing other complications of diabetes too. So I will explain a little bit detail in this slide. This is a beautiful study done by Mogensen and et al. To show the natural history as well as describe the stages of diabetic kidney disease. As you go from zero at the onset of the disease to very many years, you can see it going through the different stages of diabetic kidney disease. The first stage is called glomerular hyperfiltration, where you can see the red line is what it says about the GFR. So initially there will be a hyperfiltration, an increase in GFR, which can sometimes fool us too as clinicians. If you do the ultrasonography, you might see an increase in kidney size. As you all know, kidney size typically is 10 to 12 centimeter, and you might see an increase in the size in the kidney. You don't see much proteinuria. This blue line shows the proteinuria, which you may not see much during that stage. The second stage is something called silent stage, where the hyperfiltration is over and you see a normalization of GFR. You might see structural changes happening in the kidney, and you might or might not see microalbumin. By the third stage, incipient stage, which lasts from 5 to 10 years, you start still the GFR relatively stays normal, and you might start seeing the rise in proteinuria, especially to the microalbumin range, which is like 30 to 300 milligram per day. If you continue to let the hyperglycemia persist, then you see the stage 4, which is overt nephropathy, where you see a drastic reduction in GFR, as you can see from the graph, and a big rise in the proteinuria, especially to macroalbumin range, which is more than 300, or even to nephrotic range proteinuria, which is 3000 or 3500. You start seeing increased incidence of hypertension in these patients. You start seeing retinopathy changes, and kidney size might, due to the lesser hyperfiltration and all, you might see a normal kidneys with the ultrasound. And that stage usually is seen clinically between 10 to 20 years. And if you still continue to let the hyperglycemia persist or proteinuria persist, then you might unfortunately see the end-stage renal disease stage, where patient have to depend on peritoneal or hemodialysis. So as we looked at it, all these changes usually happen as hyperfiltration in the glomerulus, which can lead to a lot of hemodynamic, metabolic, and inflammatory changes, as well as intracellular changes, leading to all these pathological changes that we talked about. So this is on the left side, you have a normal glomerulus, and this diagram depicts what happens in the glomerulus. As you can see in the green structure here, you have the glomerular basement membrane, which is much thickened compared to this. You see loss of podocytes. You lose loss of podocytes on the right-hand side, as well as effacement of the food processes here. And the main thing is also about the mesangial expansion that happens compared to this normal slide. This is also a picture of the normal glomerulus here, and you can see stages of inflammation happening, and more mesangial expansion, to the point where you can see the Schimmelstein-Wilson nodules, like I mentioned in the historical section, that these are pathognomonic of a diabetic kidney disease. This is the electron microscopic picture. It's a normal glomerulus. As you can see, the basement membrane not much thickened, as well as you can see the food processes there, but which is not very appreciated in diabetic kidney. You can see the mesangium is much expanded here. You can see the thickening of the basement membrane as well as loss of those food processes. So let's move on to the diagnostic methods. The gold standard remains renal biopsy, but fortunately, we don't have to go for renal biopsy as being an invasive procedure. We don't have to rely on it as we are able to, as good clinicians, we are able to take good history and lab evaluations to make the diagnosis. The diabetic kidney disease is defined as persistently high urinary albumin to creatinine ratio, more than 30 milligram per day, or reduction in eGFR below 60 ml per minute, and long duration of diabetes as explained in natural history around 10 years, as well as diabetic retinopathy. So screening recommendation for diabetic kidney disease is with urine protein to creatinine ratio as well as serum creatinine and eGFR measurement. It's recommended annually for type 1 diabetes beginning 5 years after the diagnosis, and annually for all patients with type 2 diabetes beginning at the time of diagnosis. So in like I mentioned, in patients with proteinuria, diabetic retinopathy is a strongly suggestive of diabetic kidney disease, and the preferred test for proteinuria remains urine albumin to creatinine ratio. A spot sample is fine, preferably in the morning, and you should at least have two out of three samples positive, collected over 3 to 6 months period, just to make sure the proteinuria is persistent and not just transient proteinuria. The eGFR should be calculated based on the serum creatinine concentration. You could use CKD EPI equation or MDRD equation. Both are acceptable. So like I said, biopsy is not typically considered, but some of the scenarios we may have to rely on biopsy to make a diagnosis, especially there is atypical presentation of kidney disease. Like I mentioned, if there is absence of retinopathy, especially in type 1 diabetes, or if you see albuminuria less than 5 years or more than 20 or 25 years after the onset of disease, if you see immunological markers, or patterns of nephritic syndrome or hematuria or a rapid decline renal function, you may have to depend on the kidney biopsy to make a diagnosis. So let's move on to the therapeutic area, or how you approach the therapy of diabetic kidney disease. 60 years ago, a diabetic patient with proteinuria might have only survived to 3 years. So thankful to all the great clinicians out there and all the new drugs that we have, the survival is much longer now, but we still have seeing a lot of great burden in the in morbidity area. So early diagnosis is still the key and have shown better treatment outcomes. So therapeutic goals should be to prevention of diabetic complications, especially diabetic kidney disease, by long-term intensive very early on in the course of the disease. Why? Because the intensive glucose control after the onset of complications, or if you let the diabetes run long-standing, then it has not shown much reduction in the progression of the disease or even into improving overall clinical outcomes. So target A1C should be around 7% with the kidney patients. For dialysis patients, we recommend around 7 to 8%. The lower A1C goals of 6 to 6.9 hasn't showed much reduction in cardiovascular or microvascular complications in this population. And also you have to keep in mind the risk of severe hypoglycemia and its deleterious effects. So American Diabetic Association recommend target based on age, comorbidities, or life expectancy. Again, I have to mention that if you look at different, as you all are aware, like different association may have different guidelines. I just have to stick with a few, and you all can read about it. So ADA recommend more stringent goals like A1C of less than 6.5 very carefully. If patient is younger with shorter duration of diabetes and not much complication, or if they have longer life expectancy. But if the case is otherwise, like older age with more complications and limited life expectancy, better to have A1C less than 8, again to the risk of hypoglycemia. So regarding each agents in different class, sulfonylureas are still used a lot. Better to use short-acting glipizide or glimepiride. Biguanides, metformin, like mentioned by the previous speakers, like a wonder drug, we still consider as wonder drug, still have a lot of good effects. But kidney-wise, you should be avoided with a GFR of less than 30 ml per minute. Always be careful with acidosis. Renal dose of rapaglinide and natiglinide can also be used. Regarding DPP4 inhibitors, linagliptin does not need much renal adjustment. Sita and Saxa does. Thiazolidinediones like pioglitazone are typically avoided, especially with the presence of edema or CHF. Alpha glucosidase are also not much recommended. Insulin therapy is considered, especially if patients fail therapy, and always start with a lower dose. You don't need much dose adjustment if GFR is more than 50. Hemodialysis patient, we prefer oral. The hypertension management. We again for the type 1 diabetes, we see 5% of the patient having hypertension at 10 years after the onset, 33% after 20, and 70 after 40. We see a close relation between hypertension and albuminuria, and volume expansion and increased arterial stiffness is considered the culprit. Based on the different trials, the blood pressure goal, especially by JNCA recommendation, is 140/80. Again, the recommendations might change. Regarding the initial agents of choice, you could have the thiazide diuretic, calcium channel blocker, or ACE or ARB. Especially if there is albuminuria, you need to include ACE or ARB. And combination is not recommended due to hyperkalemia and risk of acute kidney injury, and no much clinical benefit based on the on target and the VA nephron study. Beta blockers are less favored, as mentioned before, due to masking of hypoglycemia symptoms and reduced exercise tolerance. Carvedilol has shown some advantage. Alpha blockers should be avoided due to orthostatic hypertension. Lipid lowering agents should be considered. Lifestyle modification should always be considered, including dietary intervention, regular exercise, weight loss, and smoking cessation. Regarding newer agents, there was extensively studied leader study and sustained 6 study. They have shown better cardiovascular outcomes and slowed the progression of kidney disease due to the mechanism of action like glycemic control, weight control, and direct effects on the kidney. So they could be used with caution even in advanced kidney disease like liraglutide, dulaglutide. Exenatide is used mostly early diabetic kidney disease. SGLT2 also been well studied recently, like studies like EMPA-REG outcomes study. They have showed lower rates of death from cardiovascular disease and heart failure, hospitalizations, and death from other cause, and also shown better clinically relevant kidney outcomes like less nephropathy and doubling of creatinine. So they could be also used like DAPA, CANA, and empagliflozin, shown beneficial early kidney disease, not effective if GFR is less than 30. There are some novel agents being studied also targeting glomerular hyperfiltration, inflammation, and fibrosis. So in summary, we have talked about diabetes as a leading cause of kidney disease. We talked about the screening tools and criteria for albuminuria and eGFR. We talked about the goals of therapy, including A1C goal as well as hypertension goals. We talked about the agents of choice in each class as well as renal dosing. We talked about the newer agents as well as the cardiovascular benefits. So by that, I would like to thank you all for the attention, and again thank you for the great effort put by the organizers in organizing this event and giving me this opportunity. Thank you all, and I'll be happy to answer any questions or hear any comments.
Thank you, Dr. Rajesh, for that excellent lecture. I think we will take up the question answers at the end of the session. We'll take the question answers after the other sessions.
Okay, thank you so much. Thank you. I will be available then. Thank you.
You are welcome.
Hello, good evening to all. The next talk is on remote blood glucose monitoring system, a boon for diabetes management in pandemic. To talk on this, we have an eminent speaker, Dr. Manoj Chawla. He is a senior consultant diabetologist, Lina Diabetic Care, Mumbai, and is a lecturer for the postgraduate diabetology course conducted through CEP, Mumbai. He has been principal investigator for various global clinical trials for new anti-diabetic drugs. The co-founder of United Diabetes Forum, an organizing chairperson for Challenges in Diabetes. He's a reputed speaker in many national and international forums. Over to you, sir.
Thank you, Dr. Ravindran. Pleasure being introduced by you, and thank you, Dr. Rasheed and team, to invite me here. Okay, finally, I can see my host rights to be able to share my slides. The topic that I've been asked to speak for is remote blood glucose monitoring systems, a boon for diabetes management in pandemic situation. There's a disclaimer that I've been asked to speak for this specific product, Contour, and their new glucometers, and emphasizing on the impact of SMBG in India. So maintaining a good glycemic control is, of course, crucial in the management of diabetes because it would otherwise be associated with micro and microvascular complications. SMBG today we realize is a simple and practical tool for maintaining good glycemic control. But when you look into the Indian perspective on SMBG, there clearly seems to be lack of education about the purpose of SMBG and the correct process and schedule. It's been pretty unclear in terms over the years about how often should you do it, what you should do about that data. And hence, over the years, because it's a self-pay market, it has led to very limited SMBG practice in India. And there's been an unmet need for country-specific SMBG recommendations till, of course, a few years back when some of us were invited as part of the RSSDI consensus on self-monitoring of blood glucose. This was led by Dr. Makkar from Delhi, and many other colleagues joined in to come out with the RSSDI recommendations for SMBG in type 1 and type 2 patients. Now, these are the recommendations that we came out with, which speak about the frequency for SMBG in patients with type 1 diabetes, then in type 2, those who are on oral anti-diabetic drugs, type 2 on insulin with or without OADs. But what we also did was spoke about the SMBG frequency in limited care. So this is the ideal aspect as to the frequent readings required. And then in limited care, where there are issues with constraints of finances and availability, then we came out with limited care recommendations that there should be at least minimal SMBG done in these patients, again, differing between the type 2 and type 1 group. We also spoke specifically about the recommendations for different insulin therapies. If somebody is on basal insulin, we spoke about doing fasting levels at least twice a week or once in 3 days. And then if somebody is on premix insulins or a basal bolus regimen, then an increased frequency from safety and lack of hypoglycemia point of view. So moving ahead, when we talk about the emerging technologies, which is changing the horizon of diabetes management, well, clearly today, when we speak about continuous glucose monitoring, then moving on to the more recent flash glucose monitors, which have become the norm, it's now moving towards the connected meters. So we're not looking at plain simple glucometer usage, but towards connected glucometers, because all of this is making it extremely simple and convenient for the end users, that is the patient. It allows remote monitoring. That means the patient and the healthcare practitioner can share the data. And similarly, this can be shared with other families which may be anywhere across the globe. So extremely patient-friendly aspect, which is leading to an integrated diabetes management. So diabetes management is evolving. Greater connectivity within patients, healthcare practitioners, and payers. You have smart blood glucose meters, patients who are ready to do their lifestyle intervention, keeping their healthcare practitioners involved in their choices. All of this allows us to interconnect the diabetes management, because this is the need of the hour. The conventional aspect that we've been doing, an occasional SMBG, non-structured SMBG, or just going to the laboratory once in 3 months, getting a reading done, maybe even an HbA1c, we may be losing a lot of touch points as to where we can help the patients more. So an interconnected diabetes management where the patient is not only checking regularly, but has the means of sharing the data with the healthcare practitioner and the family, which can keep a watch and keep guiding the patient, seems to be the need for the hour. So new opportunities for digital health to thrive. So mHealth or mobile health is defined as the delivery of health services and improvement of health outcomes via mobile and wireless devices. And this has been a boon, especially in the last 4 to 5 months of the lockdown because of the pandemic. This is what has allowed patients and us to remain connected. They've been doing more SMBG. They've been sharing the data through means of these kind of apps and technologies that we have, and allowing us physicians to help the patients to maintain good metabolic health. So mobile app technology can empower patients to better manage their disease, and digital health can be useful to not only support diagnosis, but the monitoring can lead to changes in behavior to support treatment and prevention. Let's understand and remember, in diabetes, unless you monitor, you will never know how you're doing. It tends to be a silent disease and a silent killer, and it's the only way to figure out as to how what kind of metabolic health you're maintaining monitoring is the biggest mantra for patients with diabetes. So the information, motivation, and behavioral skills model is what we are talking about. Information, people with diabetes require actionable information, and hence the kind of SMBG that they needs to do needs to be discussed and explained to them, which is structured and which is going to be effective. This also leads to motivation, where patients with diabetes need to be motivated to act on information. So spending time and explaining the required changes based on the information that they get through monitoring motivates the patients to do better. And of course, this also enables them to adopt behavioral skills, which will require them to, or help them rather, to improve for their metabolic health, whether it is changes in their lifestyle, changes in their exercise, changes in their diet, and so on and so forth. Here we are introducing the Contour Plus One system. This is the Contour Plus One system, which is a meter tailored to different patient needs. Well, it is informative. So patients are provided with instant feedback through the smart light feature. Those who even want to just tap it, they can start seeing the light to make sure that they are introducing the strips correctly. It is remarkably accurate as per the ISO standard, and it is a very simple to use machine. Now, this is the components of the Contour connected system. You have the test strip, you have the meter, and then you have the app, which can be downloaded easily on the iOS or the Android systems. And then, of course, this gets connected through cloud, maybe share information with doctor or any of the other family members anywhere in the world. Contour Plus One meter helps your patients to test their blood glucose with confidence. You can just double tap here, so you get the light. You introduce the strip here, insert the test strip, and apply blood to the Contour Plus test strip, as simple as it's seen here, which a lot of other meters also have, but this really makes it look much, much simpler. It has a smart light feature, I think, which is appreciable, and I'll tell you why. So the smart light feature instantly tells your patients if their blood glucose reading is within the target range, and you get the green color. Above the target range, where you get the yellowish orange color, and red, which is the below target range. Now, what is different as compared to some of the other systems is the other systems have given the color red if your sugars are in the higher range. But I'm sure all of you will appreciate that hypoglycemia is a bigger red signal and danger than sugars in the hyperglycemic range in the acute short-term period. And hence, I appreciate this color coding here, where the red is given the below target range as a sign and signal that the patient needs to take action. Of course, if it remains in the yellow-orange zone for a long time, you need to consult your doctor as well. Importantly, we always hear from patients that by the time they could introduce or touch the blood strip, the glucose strip with the blood sample, the machine went off and the strip was wasted. Now, which is where they have improved here, that there is a second chance sampling. If somebody hasn't gotten sufficient blood through the prick, they can re-prick and get a drop of blood, and they will not land up wasting the strip, and of course not land up wasting the money. So this has been one important reason, the improper usage or the wastage of test strips, which has led to patients not doing frequent SMBG, and machines and systems like these definitely are helping us in changing that. So blood glucose monitoring systems perform better when highly accurate. This has a smaller, less than 10% error of margin, which has been one of the landmarks and accepted levels. And then you have the Contour Diabetes app, which is an easy to use and easy to teach tool designed to manage diabetes, reducing the effort needed to capture the data. So automatically, when you are using that through Bluetooth, the information gets transmitted and available in more than 50 countries. Contour Diabetes app contains insightful feature. So you can review your results. You can add events to the readings. If you see a high reading and today I had indulged, or there was a festival, there was a celebration, you can add that comment. You can also set up smart alerts that if my sugars are constantly, there's a pattern of it going low at a particular time or going above, I'll get an alert. Structured testing reminders, again, can be inserted into this app, and easy shareable results. Some of the selected app features which I'm showing here are my patterns. So here you can see that the patient can identify their patterns if they want to see what's happening to me on every Monday. For some reason, my Monday is different from other days. Maybe I have a holiday on Mondays, so is my pattern different? I want to see reports in a different format. I want to see the entire log. I want to see what's happening in the last 15 days. I can have my test reminder plans. Am I due for my testing? Am I due to see my physician? And of course, those who are on insulin, and especially the type 1 patient, those who want to enter the data for their carbohydrate intake and try and match the insulin to carb and measure the insulin to carbohydrate ratio, again, there is means of entering this data and matching the insulin and carbs. Now, this is a study which I'm quoting, which showed real-world evidence in more than 5,800 patients with people with diabetes, which showed that the use of Contour Diabetes app for more than 180 days significantly decrease the likelihood of hypoglycemia, significantly decrease the likelihood of severe hyperglycemia, which was more than 250, significantly increase the blood glucose testing to 4.5 times a day. Because this was accurate in helping the patients, the frequency increased in these patients and showed consistent beneficial effects on prevention of hypoglycemic events. The Contour Diabetes app also allows easy sharing of results. And this easy sharing, as I mentioned earlier, is a boon because sometimes when you're worried about your family and you're living separately, again, I refer to the times in the pandemic, families living separately, different cities, lockdown, different countries, you are able to monitor and track the health of your loved one because whoever is using the Contour and the app is able to share their data across with family as well as the healthcare practitioner. The structured patient reports can be sent directly to the healthcare practitioner, and that again is helping the digital connectivity in times of telemedicine today. We've been using a lot of these apps and the connectivity with the patients, asking them, those who are afraid to get out for testing, not even wanting to come to the clinic, stay at home, stay safe, monitor your sugars, please send us the data, and we'll interpret and help you with what needs to change, if something at all. How to install the app? I think very simple. You could get on to the App Store or Google Play, and this can be for every patient and user, they can install it. Finally, let me remind all before I end that SMBG as a component of the education and treatment program is extremely crucial. Even though there are advancing technologies, we may be using a lot of CGM and FGM, SMBG still continues to be extremely relevant and widely used. It's important for diabetes education and understanding, important for glycemic assessment, extremely important to introduce behavioral changes and optimization of any therapy we use, be it insulin or the oral drugs. And the impact of all of SMBG towards improved metabolic and clinical health, the safety of the patient, improved quality of life, and of course, economics in the long run. Today, if you remain under control, you'll avoid the cost of complications in the long run, and that's what we need to explain to our patients as well. Thank you all so much for the patient hearing. Handing it back to the chairperson, and thanks again, Dr. Sabir, for inviting me.
Thank you, sir, for the excellent presentation. The topic is open for discussion. If there are any queries, please unmute and ask.
Thank you, Dr. Ravindran, for taking the queries here, because if there are any, I'll be happy to answer. I need to jump into another session in half an hour, so I may not be able to wait for the full session.
Okay, sir.
Any queries, please, I'll be more than happy to answer them.
Thank you once again, sir, for your excellent presentation.
Thank you, and wishing you all the best. And hi, Dr. Sunil, Kota, and I'll catch a bit of your presentation before I move out. All the best. Bye-bye.
Hi. Thank you, sir.
We can move on to the third topic, which is every ultrasound abdomen shows fatty liver. What to do? To talk about this, we have with us Dr. Sunil Kota, a senior consultant endocrinologist, diabetes endocrine clinic, Berhampur, Odisha, India, and he is a speaker in many national forums. Over to Dr. Sunil Kota, please.
Very good evening, everyone. Respected chairperson, respected esteemed audience, and thanks to Sabir sir for inviting me over here and asking me to talk on a very important topic, practical, I would definitely say, because this is one of the very common scenario that we frequently stumble upon when ultrasound shows fatty liver. What are we supposed to? Through an index of 42-year-old female, banker, obese, not having any diabetes, hypertension, neither the family is having any history of diabetes, hypertension, dyslipidemia, or cardiovascular disorder, but she is on rosuvastatin for 10 milligram for last 1.5 years for hypercholesterol. And lab parameters showing elevated enzymes, liver enzymes, the triglyceride is high, and there is increase in both fasting and postprandial blood sugars. Ultrasound showing parenchymal hyperechogenicity of the liver and poorly visible intrahepatic blood vessels, which is classical to be depicted as a mild fatty liver. So with this background, I'm going to take you through my presentation proper. First of all, I would like to take you through the etiology. Causes obviously are the alcoholism. They stated more than 20 grams per day for males and more than 14 grams per day for females is associated on a long term with fatty liver. Obesity, hyperlipidemia, diabetes, genetic causes, starvation and rapid weight loss, hepatitis C, parenteral nutrition. Then you can see the fatty liver of pregnancy, some metabolic condition and inherent conditions of transport disorders. Then the medications like aspirin, tetracycline, amiodarone, immunosuppressive agents, valproate, and anti. So it is in Asian context, most of the guidelines state that for Asians, the weekly intake of alcohol should be less than 140 grams per day for males and less than 80 to 100 grams per week for females. And looking at the slide, you can actually calculate what is the amount of different types of alcohol. I don't think it's a news to anyone. So if you talk about the NAFLD, which happens to be the hepatic manifestation of metabolic syndrome, because I'm not going to talk about the alcoholic component, I'm predominantly going to talk about the non-alcoholic component. It is the metabolic component, the hepatic component of the metabolic syndrome, and it is associated with obesity, insulin resistance, dyslipidemia, and whatnot. And if you talk about prevalence globally, it is somewhere between 15 to 46%. And if you look at the Asian data, it is somewhere between 10 to 39%. And it is in India, you can see there are studies which have quoted the prevalence to the tune of 28 to 35%. And it is one of the most common cause of elevated transaminases, cryptogenic cirrhosis, and cryptogenic hepatocellular carcinoma. And thanks to so many conditions as it can be depicted on this slide, obesity, metabolic syndrome, urbanization, sedentary lifestyle, and so if we talk about the etiopathogenesis, we all understand the risk factors associated with NAFLD, obesity, type 2 diabetes, dyslipidemia, metabolic syndrome, and there are some other hormonal disorders like hypothyroidism, hypopit, hypogonad, polycystic ovarian syndrome, and obstructive sleep apnea as well. And NAFLD risk prediction tool would always be handy. And you can see there are factors like hypertension, diabetes, the enzymes, sleep apnea, and the race. All these point to a score which would be telling us about the risk to progression to in the future. Then this is the two-hit hypothesis which is there since long way back in 1998. The first hit is by the metabolic alteration of hyperlipidemia and hyperglycemia, normal liver into steatosis. Then we have the impact of oxidative stress and inflammatory cytokines, which gives the second hit, converting it into a steatohepatitis. And if you look at the spectrum, either it is a fatty liver when more than 5% of the liver is having fat accumulation, NASH when there is accompanying inflammation and scarring, and cirrhosis when the scar tissue replaces the liver cells. And why it is important to differentiate between NAFLD and NSH, and if you can look at the slide carefully, over a period of 30 years, if the diagnosis is shifted to NASH or the steatohepatitis, there is a significant reduction in chances of survival. And if you look at the natural history also, 15 to 30% of the healthy liver would go on to NAFLD, 12 to 40% of these would go on to NASH, out of which 15 to 25% would go on to cirrhosis, 50% of them would die or have liver transplantation, and 7% would go on to have hepatocellular carcinoma. Then how do we diagnose this? That the evidence of hepatic steatosis has to be demonstrated either by imaging or histology, and we have to rule out all these secondary causes of hepatic fat accumulation that we have discussed earlier. And this slide basically tells us about the distinction between macrovascular and microvascular steatosis. And this is the guideline in American Journal of Gastroenterology 2012. There are two scenarios that they have pointed. The scenario one is whenever there is hepatic steatosis in imaging in presence of symptoms or signs of liver disease or have abnormal liver biochemistry, they have to be suspected and evaluated thoroughly for NAFLD. And the scenario two, when you find hepatic steatosis in imaging, but no symptoms or signs of liver damage or no elevation in enzymes, we have to assess and alternate cause of steatosis. So this is the guideline of elevated liver enzymes or evidence of hepatic steatosis in imaging. If the patient is subjected to any other surgery like bariatric surgery or cholecystectomy, you can straight away plan for biopsy. If not, the baseline workup can include the complete blood picture, platelet count, the enzymes, then glucose, lipid profile. Then you can give a trial of 3 to 6 months of diet and exercise. If unsuccessful, you can plan for liver biopsy in presence of high AST, ALT, high AST platelet, decreased albumin or platelet. If not, again, reassess after 6 to 12 months. Why ultrasound is picked up? Because it is very easily accessible, less costly, no radiation. The simple principle is that the echogenicity of liver is equal to that of renal cortex and spleen, and the intrahepatic blood vessels should be clearly discernible and the posterior margin and the diaphragm should be clearly delineated. So if there is obliteration of all these parameters, these are graded according to the ultrasound. Grade 1, presence of echogenicity. Grade 2, obliteration of blood vessel. Grade 3, obscuration of diaphragmatic outline. So the disadvantages are also there. It cannot be used in obese patients, those who are having pre-existing chronic liver disease, and whenever the steatosis is less than 20 to 30%, and the degree of fibrosis can also not be graded, which is the most important parameter of mortality in this group of patients. CT scan is never used. MRI or MR spectroscopy can be used, but they do not tell you about the differentiation between NASH and NAFLD. So then there is the MR electroscopy, elastography rather. So it basically tells us about the advanced fibrosis diagnosis. So you can look at the bottom, the MRE stiffness, if it is more than 3.63 kilopascal, it is somewhat suggestive towards occurrence of fibrosis. As I was telling you previously, the most important parameter of mortality is fibrosis. So we need tests which will tell us about the fibrosis. There are some non-invasive tests like the elastography or the fibroscan, which we all are aware of. Then there are some non-invasive tests like NAFLD fibrosis score, which takes into account age, hyperglycemia, BMI, platelet count, albumin, AST-LT ratio. Then there are some number of scores, BARD score, FIB4 score, and this slide is for completion's sake. Look at the number of scores, those are available to look at the fibrosis. There are some as well. The predominant ones are the cytokeratin K18 and terminal peptide of procollagen 3. Of enhanced liver fibrosis score, which takes into account 3 parameters of hyaluronic acid, PIINP, then PIMP, and look at the interpretation more than 9.8 suggestive of severe fibrosis. Fibroscan, it is a pulse echo ultrasound technique, non-invasive, more sensitive than the serological markers, evaluates a larger part of liver and might be unreliable in obese. So you can see it is graded from F0 to F4 depending on the kilopascal value of the elastography. And sometimes also require liver biopsy, especially in patients with NAFLD who are at increased risk to have steatohepatitis or advanced fibrosis, and in those where we want to rule out the competing etiologies causing NASH. So this is the scoring pattern. This is called SLB, steatosis, lobar inflammation and ballooning more than 5 is suggestive of NASH. Then there is a fibrosis staging as well from 0 to 4. Again, 1 is divided as 1A, 1B and 1C. So now coming to the management options, non-medical, we all understand the importance of diet and exercise. I'm not going to harp much on that. How do we go to do that? But the treatment is basically to take care of the first hit. We need insulin sensitizers and anti-hyperlipidemics. To take care of the second hit, we require antioxidants and anti-inflammatory cytokines. So weight reduction is very important. So you can see a number of studies, all of them have given us good effect in terms of reduction of the histological activity score, the enzymes, the weight and all. And depending on the weight list, there can be improvement in liver fat and liver stiffness, improvement in NASH activity score. And with more than 10% weight loss, you can see 90% of the patients can also go for NASH revolution. Again, for the completion's sake, there are some anecdotal evidence in favor of these all diets which have shown some beneficial effects in patients having NAFLD. But when it comes to pharmacotherapy for all these fatty liver, when do we treat it? So the population of interest is to treat patients having NASH, NASH with fibrosis, advanced fibrosis, NASH-related cirrhosis. But do not treat the patients who have only NAFL or steatosis alone. These are the patients for whom we should be doing thorough metabolic workup. Thiazolidines, we know insulin sensitizers, but the main mechanism is to decrease the hepatic fatty acid levels and redistribute fat content from liver to peripheral adipose tissue. A number of studies are there, both in favor of pioglitazone and rosiglitazone, in terms of reducing the enzymes, in terms of improving the histological parameters. And the gastroenterology journal says it can be used to treat steatohepatitis in patients with biopsy-proven NASH, but long-term efficacy and safety is not established. What about metformin? Yes, there is weight reduction, improvement in insulin sensitivity, there is reduction in transaminase, regards to histologic improvement, we have still data to gather. So as of now, it is not recommended to be used in patients having NASH. And one of the very significant molecule is the vitamin E, which is antioxidant and a free radical scavenger. Number of studies just to showcase what all it has in store for us. But this is the most important PIVENS trial where pioglitazone 30 and vitamin E 800 was compared versus placebo. Both the molecules were better than placebo in terms of histologic improvement. But if you compare vitamin E versus pioglitazone, again, vitamin E scores better in terms of enzymes reduction, in terms of weight parameter also. Though both of these are actually associated with reduction of insulin resistance, the weight is going up with pioglitazone. So where do we use the vitamin E? It improves NASH, yes. It reverses NASH, yes. But those who have NASH with fibrosis, there is no data, and there is no data with regards to improvement in long-term outcomes. And when do we use it? The guidelines are clear-cut. They say that it can improve liver histology in non-diabetic adults with biopsy-proven NASH, and therefore it should be considered as a first-line pharmacotherapy for this patient population. But for the one who have diabetes, one who have no liver biopsy report, one who have already developed cirrhosis or a component of fibrosis, probably this is not one such molecule to be used. But again, there are some studies showing increase in all-cause mortality, increase in risk of hemorrhagic strokes, especially for the older population, those who have hypertension should be avoided. And again, there is an increase in risk of prostate cancer. Number of others like vitamin E, vitamin C, polyphenols, the omega-3 fatty acids, all these are touted to be liver protectants and antioxidants. Pentoxifylline again is a phosphodiesterase inhibitor resulting in decreased activity of TNF and TGF. There are studies, but again, not much of activity in reducing the histologic scores. Orthodeoxycholic acid is being again used, but you look at the histologic parameters, it has no such beneficial effect. So it is stated that it is not recommended for treatment of NAFLD or NAFSH. And yes, we all are aware of the dual PPAR alpha and gamma agonist, the saroglitazar. It reduces the lipids, it reduces the glycemic control, it reduces the hepatic enzymes, and on top of that, in liver biopsy, it gives rise to reversal of hepatocellular steatosis, ballooning, and inflammation. Bariatric surgery, the secondary outcome, we have seen improvement in NAFLD. So as of now, it would be premature to consider for bariatric surgery as an established option to specifically treat NASH. Statins, yes, we have improvement in terms of enzymes, but histologically, we do not see much of significant improvement. So it should be used only in those group of NAFLD and NASH who have dyslipidemia. They cannot be used as a primary treatment for NAFLD. So others like gliptins, the glutides, the gliflozins, again, especially for the ones who have diabetes, they have shown good amount of reversal of NASH. There are a number of emerging therapies. In fact, I cannot spell most of their names also. These are they are mentioned on the slide for all of you. So there are some therapies which are associated with reduction in fibrosis like vitamin E, pioglitazone, obeticholic acid, cenicreviroc, then selonsertib. So probably, excuse me if I'm spelling it wrong. Lastly, how do we treat it? So predominantly, we have to exclude the secondary causes, take care of the risk factors. If these are present and the patient is willing, you can go for liver biopsy. If these are absent, lifestyle modification is the answer. And if liver biopsy is establishing a NASH, then the chance of lifestyle modification, pharmacotherapy, and bariatric surgery coming into the picture is. How do we follow up? Once in 6 months, weight and exercise has to be checked, and the blood platelet counts, the liver biochemical tests, prothrombin time. Then the screening for cardiovascular risk has to be done once in 1 to 2 years, and liver biopsy again every 3 to 5 years, depending on response. NAFLD is definitely a significant health issue in India, and fatty liver, ultrasound, try to rule out alcohol, then comes the NAFLD, and it is closely associated with metabolic syndrome. It is called as the hepatic component of the metabolic syndrome. Its presence also indicates co-presence of other metabolic disorders of diabetes, hypertension, and dyslipidemia. In 80% of the cases, it is a reversible benign condition. But if it's not treated properly and if the risk factors are not addressed properly, 20 to 25% of cases can progress to liver damage. So lifestyle modification has the best result. Non-diabetics, those who do not have cirrhosis, those who do not have fibrosis, yes, vitamin E is the best one. If there is diabetes, then try to use the drugs like gliflozins and gliptins and the glutides, which can give rise to some sort of reversal. Pharmacological treatment is still evolving, and there is no single therapy which is clearly effective. Thank you all for the patient listening, and thank you again, Sabir sir, for giving this wonderful opportunity to interact with all of you. Thank you.
The next topic is SGLT2 inhibitors and diabetic ketoacidosis. Points to remember in clinical practice. To talk on this, we have an Indian speaker, Dr. Aiyanadar Shanmugam. He is certified in internal medicine and endocrinology. He is a fellow of American College of Endocrinology, fellow of American College of Physicians, and he is a retired clinical professor of endocrinology at Texas A&M Health Science Center. Over to you, sir.
Meanwhile, thank you all for giving me this wonderful opportunity. I would really like to thank Dr. Sabir Rasheed for this, and all the organizers for this wonderful program, and I enjoyed every bit of it. It was nighttime most of the time, so we were sleeping. And when I woke up 3 hours ago, I've been enjoying every bit of it and all these wonderful speakers. And it is such an honor to be part of this program. I would like to thank Dr. Ravindran and Dr. Chako Varghese for moderating, and Dr. Ravindran for introduction. The topic given today is SGLT2 inhibitors and DKA points to consider in clinical practice. Can you all hear me okay? Can you all hear me okay?
Yes.
Okay.
Yes, sir. Sure.
Okay, thank you. We will briefly touch upon the pathophysiology of type 2 diabetes, and we'll talk about the role of sodium glucose co-transporters, DKA with SGLT2 inhibitors, diagnosis and treatment, and how to safely use sodium glucose co-transporters 2 inhibitors, which is otherwise abbreviated as SGLT2 inhibitors in type 2 diabetes. I would touch upon LADA, which is latent autoimmune diabetes in adults, and DKA, because it's very, very easy to confuse the SGLT2 inhibitors and DKA with the LADA. And we'll start off with this classic slide from the Banting lecture of Dr. Ralph DiFranzo, whom I call the godfather of diabetes. Met him several times, listened to many of his talks, happened to be there during this wonderful presentation he had on the Banting lecture in 2009, where he was given the Banting Medal of Honor by the ADA, American Diabetes Association. This topic he termed as from the triumvirate to the ominous octet. That is, from 3 causes of diabetes to 8 causes. He jumped from 3 to 8. And on the left-hand side of the slide, you will type 2 diabetes, as you all know, is a very complex metabolic disorder which ravages the body in multiple ways, more than one, with microvascular and macrovascular complications. On the left-hand side shows the increased glucose production from the liver, hepatic gluconeogenesis, increased glucagon secretion from the alpha cells of the pancreas, increased lipolysis from the fat cells, and increased glucose reabsorption, which is the main topic for today from the kidneys. On the right-hand side of the slide, you can see decreased insulin secretion from the beta cells, decreased glucose uptake, decreased incretin effect, and neurotransmitter dysfunction. So we will focus on the role of sodium glucose co-transporters in the kidneys. When we look at the glucose filtration reabsorption, about 180 grams of glucose is filtered by the kidneys each day. The action takes place mainly in the proximal convoluted tubule. As you can see, there's an S1 segment and an S3 segment. and the white little particles are the glucose molecules. And no action, no reabsorption takes place in the loop of Henle or the distal convoluted tubule. 99% of the sugar is reabsorbed in the proximal tubule. So the urine is, in a non-diabetic patient, the urine is virtually glucose-free or minimal glycosuria occurs. This is an expanded version showing the proximal tubule and the blood vessels, and these are the I'm pointing towards the white glucose molecules and the the sodium glucose. This is actively transported through membrane proteins called sodium glucose cotransporters, especially 2, because the 1 is in the SGLT1 is in the intestine, and it does the same thing there. This has been known for almost 50, 60 years. Again, I showed you here the 90% of the reabsorption occurs in the S1 segment and 10% in the S3 segment. The renal, what happens in type 2 what we saw so far is a normal, non-diabetic patients. What we would see now is in a diabetic patient, a maladaptation occurs. So the kidney has a more than 32% increased capacity for glucose reabsorption compared with the kidney in a healthy patient. So what happens is that there is already hyperglycemia, and the renal threshold maximum is also increased from 180 to about 240 milligrams per cent. In other words, even up to the fact the blood sugar is 240 milligrams per cent, instead of glycosuria, you get more reabsorption. So you add insult to injury and you get hyperglycemia and you get more chronic glucotoxicity. The SGLT2 inhibitors came into existence about 7 years ago, 2013. Prior to that, we had a non-SGLT1 and SGLT2 inhibitor combination, which was called fluorescein, which was from the bark of an apple tree. And that didn't work because it was too toxic and could not be utilized. So we had to wait 30, 40 years, even after we knew this mechanism, before a drug that can be clinically used came into existence. Canagliflozin, dapagliflozin, and epagliflozin are the 3, Invokana, Farxiga, Jardians in that order. And what are the advantages of these inhibitors, SGLT2 inhibitors, is that oral administration as an AM dose, weight loss, modest weight loss occurs, potent A1C reduction, and no hypoglycemia unless used with insulin or sulfonylurea. And again, once a day can be used along with most hypoglycemic agents and insulin. Subsequently, we found out that there are through outcome studies, we found that there were more benefits, cardiovascular benefits were shown. And recently, in June of 2020, the Food and Drug Administration USA approved dapagliflozin or AstraZeneca's dapagliflozin for congestive heart failure treatment, both with diabetes and even without diabetes, which is incredible, increasing the importance of these drugs, class of drugs. Reduction of cardiovascular events and death occurred with dapagliflozin as a secondary prevention studies, not primary prevention as in statins. CKD with chronic kidney disease, delay in progression of CKD was known. The side effects being UTI, and the patient should be informed to drink more water. And as you can imagine, the urine is full of sugar, and if the patient doesn't drink enough water, then you can concentrate urine. That's a setup for risk of urinary tract infections. Genital myocardial infections, especially in women, about 10% of the cases, and 3% of the men can develop that. Those have these drugs are started on. Dapagliflozin has a very minimal association. I put a question mark there because it's in the PI, which physician information or the prescribing information. It's not advisable to be started in patients with a prior history of bladder cancer or active bladder cancer. Canagliflozin has a risk of lower limb amputations, fractures. The mechanisms of these are not clearly known, but be that as may, that's what we have. Precautions in the use of these drugs should be kept in mind. They are not to be used in advanced CKD or ESRD or patients with dialysis. That's any patients with renal function of less than 7%, less than 30%, meaning EGFR of less than 30, or dialysis. Not because they are nephrotoxic, but they're ineffective. They cannot cause glycosuria in those patients. And then they are not effective. History of recurrent UTIs, already you have a risk of UTIs. And if somebody has a history of recurrent UTIs, I would stay away from using these drugs, even though they have been used by some. History of recurrent yeast infections in a patient then may not be the right class of drugs to use because we have so many other classes to use. Type 1 diabetes, it's not indicated. Dr. Ann Peters out of California, UCLA, was one of the earlier ones that showed, she published in Diabetes Care, showing about 13 episodes, only 9 patients. That means there were more than one episode in certain patients. And if you can see on the right-hand side, about 7 of them had type 1 diabetes. So it's not approved, but they are researchers and they can use it. I'm more of a clinician, and I had clinical practice, and I was a teacher, but more of a, most of my time was clinical practice. And I would like to give a, disclaimer that I was a speaker for all these companies for a very long time until I retired 4 years ago. And I'm not a speaker anymore. So just wanted to let you know, I was a speaker for all these drugs. Two patients had type 2 diabetes in this particular study, and it occurred after post-surgical procedure. So pathophysiology and what are the risk factors, presenting factors are that decreased insulin product secretion occurs in these patients because of normalization of sugars by the glycosuria, and or exogenous reduction of insulin by doctors because the diabetes gets tremendously improved and they may get hypoglycemia and they're already on other agents. So the reduction in other agents, especially insulin, is the first thing to go because patients don't want injections, as you can see. And so these patients are susceptible for DKA. Increased glucagon production occurs as a secondary event because of decreased insulin production, decreased insulin secretion. And so you get hepatic gluconeogenesis and ketogenesis occurs. Concurrent infections, decreased carbohydrate intake. One patient did not inform one of my referring physicians that she went on a keto diet, meaning completely off carbohydrates and only eating meat and vegetables. And she ended up getting DKA, and then after she was discharged, she was referred to me. So I have not really seen, even though I had thousands of patients on these class of drugs, I just haven't seen many of them. They're very, very rare. DKA is very rare with SGLT2 inhibitors. Dehydration due to nausea of ketosis causing less fluid intake is another reason. And glycosuria causes euglycemia or mild hyperglycemia. So euglycemic decay is much more common in these patients, in those who do develop, even though this is very rare. DKA in SGLT2 inhibitors is very rare. I just want to emphasize that. And it can occur with the blood sugars of, the first few patients were reported as the blood sugars of 191. So 191, 190 to 200. So we have to be very careful with these, with not diagnosing just because the blood sugars are not high enough. Because the definition of DKA is more than 250, as you all know. Nausea and vomiting, abdominal pain, generalized malaise, and shortness of breath. And I usually tell patients when I initiate them that to drink plenty of water, and if they have nausea, vomiting, or abdominal pain, they have to stop the drug and then report to me, and I may prescribe insulin as needed. or we may send the patient for ketones, serum ketones, and even to the emergency room for further evaluation. So reduced calorie intake, pancreatic insulin deficiency, alcohol abuse, surgical, post-surgical, and again, I want to emphasize, please do not use it on type 1 diabetes. That's where most of the decay seem to have occurred because of the reduction in insulin dosing in these patients. Nausea and vomiting, abdominal pain, as I mentioned, malaise, hyperglycemia, and serum ketones, and euglycemia can also can occur, as mentioned. How much time do I have? I just have to pace my talk. 5 more minutes, 6 more minutes. Can you all hear me?
Yes.
Okay. The one unique factor is it occurs even with mild hyperglycemia and no prior usage of insulin. This was shown in the Canadian study of retrospective analysis. But most of the patients, the reduction of dose of insulin was the cause rather than absence of insulin. And these authors concluded that pathophysiology was not well known, and it was only most of these are postulated. Again, this slide shows the comparison between the occurrence of decay in DPP4 inhibitors versus SGLT2 inhibitors. Both sections, both of the group of patients had more than 38,000 patients, and if you look at the actual incidence, it was only 0.14% with SGLT2. So, or 4.9 rate of events per 1,000 patient years, or 55 patients out of 38,000 patients. So you can see it's pretty rare, and that's where the treatment of decay is very similar to any other diabetic ketoacidosis. IV fluids, IV insulin. Patients quickly recover, preferably treated in ICU, and SGLT2 drug should be stopped immediately. I just want to quickly touch on LADA before I finish the talk. The LADA, or latent autoimmune diabetes in adults, occurs after the age of 30 with positive islet cell antibodies. 3 more minutes? Okay. Initially may be treated with diet, exercise, and metformin, and subsequently, for several months, or sometimes goes on for a long time, and almost always requires insulin sooner or later. It has mixed features of type 1 and type 2, sometimes called type 1.5. Why did I bring this up? Because many of these patients who were on SGLT2 and were thought to be type 2 and developed DKA actually had LADA. So the incidence may be even lower than what we saw, 0.14%, with SGLT2 and diabetes and DKA. So DKA, if not diagnosed properly in LADA and treated with the SGLT2 inhibitors, if the diagnosis was not made, LADA makes up for about 1 to 2%, it appears, of the entire type 2 diabetes. And I have seen a few which were referred to me, and subsequently I checked the islet cell antibodies and the C-peptide, and the C-peptide was near 0. And these patients needed insulin right away. I distinctly remember a professor of, I live in a college town, so many of my patients are professors and PhD. And one of them was a geological professor who does a lot of research on the Sea of Japan. And I kept telling him I didn't feel comfortable with him being thin and taking multiple tablets. And I gave him some insulin as samples to take with him when he went to the Sea of Japan. And he emailed me back that he had to initiate insulin in small doses while he was there because he felt his blood sugars were rising up. Anyway, that's something that stays in my mind. The last slide is take-home points or decay with SGLT2 inhibitors. It's very rare, 4.9 per 1,000 patient years, as per the studies I showed you. Patients on SGLT2 inhibitors need to be educated about the risk of DKA. If patients need to drink plenty of water, if they have abdominal pain or nausea or vomiting, they need to stop the drug and immediately report to the emergency room, the nearest emergency room. That's what I always instruct them when I initiate these drugs. The doctors need to be aware of the atypical presentation of DKA because of euglycemia and easy to miss. So glucose levels may be 190 to 250 milligrams per cent. Serum ketones are positive in these patients because if we do urine ketones, we may miss the beta hydroxybutyrate, which may be predominant in these patients. We need to consider LADA since DKA is much more common in LADA than in classic type 2 diabetes. So when somebody comes in with type 2 diabetes diagnosed for 10 years, 20 years, or 5 years, and on SGLT2 inhibitors and develops these symptoms, kindly refer them maybe to a diabetologist, like most of the audience here, as well as checking those and be aware of that. I would like to finally thank all the wonderful organizers and Dr. Sunil, Rasheed, and the moderators of this session production. And the best way to learn is to teach others. Thank you very much.
Thank you, sir, for your excellent presentation. The topic is open for discussion.
I think Dr. Ravindran, we have some couple of questions in the chat box. One to Dr. Rejeesh and one or two questions to Dr. Sunil. So I think Dr. Rejeesh, one question. Can someone read?
I can read it. I'm here available. So it says how the CKD correlate with the cluster analysis, and am I doing the analysis in my area? So I think they're asking about a study, a cluster analysis study about diabetes done mostly in Europe area. I think they've done divided diabetic patients into 5 different clusters. First one mainly for type 1, like the previous presenter, Dr. Shanmugam mentioned about LADA. So they call it a severe autoimmune diabetes, called SAID, mainly for type 1 diabetes. Other 4 clusters were severe insulin deficient diabetes, or they call SIDD, SID, and severe insulin resistant diabetes, or SIRD, and mild obesity related diabetes, or MOD, and mild age related diabetes, MARD. The first one also, the first category or the cluster was positive for glutamic acid decarboxylase antibodies, and the other ones based on the clinical characteristic. We are not doing those kind of cluster analysis because there were some studies later on done even in Europe area mentioning that the clinical features are still good, but the outcomes and also we are also kind of using those clinical features mostly for the diagnosis and prognostic factors. But it's a good question. Thank you. I'm not sure who asked it, but I would like to comment the question too. Thank you.
Yeah, actually, one more question to me. So what are the approved therapy for treatment of NASH? So actually, I've already answered that in the chat, but to make it simpler, actually, as of now, only approved therapy seems to be vitamin E, which again is contraindicated in patients having diabetes and those patients having NASH with a component of fibrosis or cirrhosis. So by and large, as I understand, the biopsy is not a very frequently done procedure. The best standard treatment as of now is weight by diet and exercise. If you have diabetes, add gliflozins and pioglitazone. If you do not have diabetes, vitamin E to the standard diet and lifestyle. So that is that should be the answer actually. And I have taken you through a journey of number of drugs just to tell you how many are, but all of these are not approved.
Dr. Rajesh, what do you do for contrast studies in your diabetic kidney disease patients? What is the protocol you follow for contrast studies in your diabetic?
We technically use the GFR of 30 as the cutoff, mainly for the contrast study, and it depends on the type of the study they are using also, especially if it is for the heart cath and all, even less GFR less than 30, we may not be able to avoid that. We recommend them to minimize the amount of contrast, especially to the cardiologist, to minimize the contrast and use the low osmolar agents, and also select the patients very carefully. keep their hydration status well. If they're on diuretics or metformin kind of drugs, we may have to hold it. If ACE inhibitor, I might hold it for a few days. And if patient hydration status is questionable, I might even ask them to give some IV fluids also around maybe 2 hours before the procedure, as long as they can tolerate the fluid volume that I'm giving. Severe CHF patients, I may not be able to. So I just have to work with the cardiologist in that regard. If it is for CAT scan, we have to work with the radiologist again. I have to ask the importance of the study. Is it could be avoided? Can the CAT scan be done without contrast and those kind of questions? And again, I have to select the patients very carefully. Regarding gadolinium for the MRI, typically again GFR less than 30, we try to avoid gadolinium contrast. Again, we try to ask them to do the MRI in other regards. And also, if dialysis patient needs gadolinium, we technically have to do the hemodialysis for 3 sessions in a row, 3 days in a row. That is a recommendation. A lot of times it may not be practical clinically, but that's what the recommendation is. Hope I answered your question.
Thank you.
Thank you.
I think we are running short of time. If there are no more queries, we will wind up the session. Once again, I thank Dr. Sabir and team for giving me this opportunity to chair the session. And thank you for all the delegates and speakers.
All great session.
So thank you everyone. It was an excellent session.